Good afternoon, everyone. It is just now 2 o'clock and we are waiting for several more committee members to join. If you are a committee member, if you would, please put your name in the chat. If you are a committee member who is on the phone, if you would unmute yourself and let us know that you are here. We should be starting in just a few more minutes. We'll get everybody another moment or two to join. Thank you.
This is Kim Danzy. I'm here.
Hi, Kim. Thank you.
And this is Rachel Craig. I'm here too.
Hi, Rachel.
All right, Sharon, how are we doing on our committee membership?
Just give me another moment to recount. We had a bunch join right at the same time. I think I was waiting on at least one more, but give me just a moment, Michael. Okay, thank you. Thanks everyone for joining. Again, if committee members would put their name in the chat. If you are a committee member on the phone, if you would unmute yourself and let us know that you are here. But Michael, we do have a quorum, so you can proceed when you're ready. Thank you.
Great. Thank you, Sharon. All right, we would like to welcome everyone to our October MAC meeting. By way of introduction, I'm Michael Hales. I'm the new chair, previous vice chair of the MAC for the last 2 years. And we are going to get started here. We know that we have the meeting minutes sent out for people to review, and I just wanted to ask if any of the members of the MAC had any proposed changes to the MAC meeting minutes from July before we reviewed them for approval. Okay, then if there aren't any proposed changes, then I will entertain a motion for approving the minutes.
This is Brian. I can move approval.
Okay, thank you, Brian. Anyone want to second that?
This is Kim. I'll second it.
Okay, thank you, Kim. All right, and then we'll go ahead and if anybody opposes the approval of the minutes, let us know. If not, we will assume that everyone's in unanimous agreement for approval of the minutes. Okay, great. Thank you. We'll consider the meeting minutes approved. Thank you, Dory, for putting those together for us. And now we would like to welcome a new member to our committee. Today we are joined by Cassidy Matthew, who is a new Medicaid constituent representative on our MAC, and we'll ask that Cassidy spend a few minutes and introduce himself to the committee members. Cassidy, welcome. Right. Cassidy, we're not able to hear you if you're speaking. Okay. Well, all right. We will see if we can find a way to connect with Cassidy. Maybe we're having some connection issues there, but we'll look forward to having Cassidy work with us and hear an introduction from him as we are able to get him reconnected. Okay, for our meeting agenda today, we're going to try and do something a little different in terms of our order. We're going to start with the director's report, which has historically been at the end of our meetings, and we frequently end up getting pressed for time, and thought let's try and put this earlier in the meeting and see how that goes. And then our committee member updates will follow a little later in the meeting, where we've usually gone right into that right now. So with that, we will turn some time to Jennifer and ask her to go through and provide some updates from her perspective as the program director.
Thank you, Michael, and hello, everyone. Hope you are having a good day. Thanks for joining us for the MAP committee today. I do have several updates to share with you regarding program updates, as well as some policy that we are looking at. And I'd like to just walk through those with you now. Happy to take your questions at the end. First, I wanted to just re-announce our PRISM timeline. So our PRISM is our claims processing system that is going to replace our MMIS system. This has been a many year project. I know many of you on this call are very familiar with this work that the teams and maybe even yourselves have been involved in. The decision was made last month, as well as an announcement to modify our go live date just a little bit. And I wanted to just walk through that change with you now, so you were aware of what this was and how it impacts the Medicaid program. Originally, the system was intended to go live on January 2023. This would be the system would go live from the provider side. We've modified that timeline just a little bit to complete all of our testing and system design by January, and we will have a soft go live in January. So the system itself will be tested and complete in January, by January. What we have done is decided to delay the provider go live until April of 2023. This allows our team additional time to do training in the system so that they know a completed system. They're able to develop really comprehensive training materials, both for our own internal teams, but also for providers. This gives us enough time to really walk the providers through these system changes that they'll experience in this new system. And there's many enhancements that we know this system offers our providers, such as like immediate claims processing and also prior authorizations that are submitted online electronically. These today are done through a paper system. And so we want to be able to orient our providers to these changes and help them be aware of what's happening. And so we've made this decision to move the provider go live date till April 2023. We've talked before about a freeze that needs to occur of our current system, which is our MMIS system today, so that we can lift the data from that system into our new PRISM system. This was a 3-week freeze time frame that's necessary to do this work. This was originally going to happen in November to December, I guess December of this year, but we have now moved those dates to March 13th to April 3rd. So more is coming on PRISM as we finish up our testing and complete our system design and then move into the new year. We will certainly be communicating with you all of those changes and how we're going to roll out our provider training and information around that freeze timeframe. So stay tuned for more updates on that. I'd like to spend some time. We have several different pieces of policy that are in the works. What I've done here, first of all, is identify the different policy pieces, including I have some contracts, which are RFPs, not necessarily policy, but lumped in here, as well as some proposed dates. So please note that. But first, I'd like to highlight 2 RFPs that we are working on right now. One is our managed care dental contracts, which this RFP has closed. We are reviewing the applications that we received for this, and it's under review right now, and we'll be moving forward with, of course, scoring and making decisions on those. But that RFP has closed, and it is under review. The next RFP that I'd like to just touch on is our pharmacy point of sale system. This is open through November 3rd. This would be a replacement of our claims processing system for Medicaid, as well as our rebate functions as well. So it would be a RFP to support all of our pharmacy operations. What I'd like to talk about next are some of the policy pieces that our teams are engaged in. Certainly there is more than this, but I highlighted some of our work that is important to share around the impact that it has. First, medical respite. This was legislation that was put forth last session, not 2021, that looked at offering medical respite services to individuals who are experiencing homelessness, who require a nurse home health level of care. So we really see this as being ideal for our TAM population, our targeted adult Medicaid population that is categorized as homeless, to meet that criteria. What this offers through this amendment would be a pilot program for one facility to offer respite services. So we've been in ongoing dialogue with CMS about our waiver proposal that we submitted to them. We've been able to have ongoing dialogue about this. We are also at the same time drafting our RFP language for this facility that would take on this work. We're in our work with CMS, we believe that some of this may be done by the end of the year or the first quarter of next year. So stay tuned on more information for that, but that's sort of the time frame for these services. The next item I'd like to call your attention to is our work on autism spectrum disorder services manual. So this has been a very long project working on updating our manual and our policy that's contained within the manual. When I met with you last time, we had mentioned that we were finishing up the policy proposals and then engaging with our stakeholders. We now have met with our stakeholders on a number of times, actually, and they are providing lots of input on the proposed policy. We are evaluating that stakeholder feedback right now. We are planning on having at least one more meeting with stakeholders to walk through some of the language that's been proposed in this policy. And then we would like to move into finalizing that policy, hopefully for a January 1st timeframe. Some of these areas that we are looking at, again, still in draft, still going through the stakeholder feedback pieces. But what we're looking for, first of all, is that we're trying to, first of all, better align our language and the manual in our language with some of the established rules and standards. There was some feedback we got on our language that we had with our current manual that was creating some confusion around our providers and what we were trying to communicate. So we've cleaned that up to really help align that with our standards of care for services in this area. We've also created some updating of some codes to allow providers more flexibility in billing for various services. And the last piece is, our work has focused on really evaluating where our prior authorizations are and even considering removing prior authorizations in some areas. And this is one place on our autism policy that we are reviewing one of our prior authorization requirements with the intent of maybe removing one of those to try to reduce some of the administrative burden that providers who deliver these services experience. So more to come on this, but we are moving forward with this policy and hopefully a timeline of January 1st for approval and moving into a publishing date for that. You're also aware of our dental hygienist policy. This will go live January 1st, 2023 as well. With this did require, first of all, that Medicaid develop a new provider type for dental hygienists so that they could bill independently for services that are delivered in a public health setting. So first of all, dental hygienists, one of the things we've been working on is that dental hygienists need to apply to be Medicaid providers. So we've worked with dental hygienists to have a sort of a step-by-step guide on how to get enrolled, and also to really work with them in understanding the necessity of enrolling as a provider to be able to bill independently for services that are delivered in this public health setting. The other piece too is we've been working on really refining that code list of what the dental hygienist providers are able to bill independently for in that public health setting. So we're just about on our final draft now. We've been again working with our stakeholders on this list and going back and forth with them and dialoguing about the various components of this, but it is just about in its final draft and will be ready for a January 1st go live date. All right, the next item I just wanted to share were some questions we've had around our refugee policy. So there are no updates in our coverage policy for refugees, but some of the feedback we had been receiving to our program was that it was hard to understand exactly what services that our population applied for that had a refugee status. While many of these individuals who have refugee status do become eligible for a Medicaid program, some also become eligible for emergency only program as well. We've created some policy language that will go into our Section 1 provider manual and will be published on January 1st, which really clarifies the coverage of our refugee population. If they move into our eligible population or the emergency only, we go over the preventive codes that are qualified underneath the benefit and are able to provide greater transparency for this population that receives services. So maybe next month I'll be able to share with you some of our draft language for that policy as well. The next piece I'd like to highlight is some changes to pharmacist reimbursement for counseling services. So this is linked to the ability for pharmacists to prescribe self-administered hormonal contraceptives. So let me walk you quickly through this policy. First of all, pharmacists, just like dental hygienists, pharmacists had a provider type created in the Medicaid system to be able to bill for certain pharmaceuticals that were outlined in House Bill 178. One of these classes of drugs that they are qualified to prescribe are self-administered hormonal contraceptives. So again, in order for pharmacists to be able to prescribe, they have to enroll as Medicaid providers. But one of the avenues that we've worked on to really promote access to hormonal contraceptives is when a patient or a member is to complete the self-assessment questionnaire. This is a hormonal contraception questionnaire that's been established and available at this hyperlink that's shared here. This was developed and maintained by Doppel, where it's a hormonal questionnaire. The patient completes this questionnaire and then goes into the pharmacist for a consultation. The pharmacist will go through this questionnaire with the patient, and when they find that the patient is eligible for a self-administered hormonal contraceptive and they prescribe that therapy for the patient and bill for it, they can be reimbursed $20 for a counseling fee one time per year, and Medicaid will cover this. So this is new policy. We hope to have this available January 1st of this year. But it does certainly open up a new avenue for individuals to receive hormonal contraception at the pharmacy with a consult directly with a pharmacist who's able to go through that with them and then receive hormonal contraception, a prescription right there. Again, I just do want to note too that on the fee-for-service Medicaid side, one of the benefits too is that many of these hormonal contraceptives are available in a 90-day supply. So this is meant to kind of hopefully improve access to care for individuals rather than having to wait maybe weeks or even a month or so to get access to a primary care visit. This will offer an opportunity for a patient to get access right at the with the pharmacist. Okay. I'm going to transition over to Joe for just a moment, who is our director of our long-term services and support office, to walk us through the approval of our medically complex children's waiver, which we did receive last month. So Joe, could I just transition over to you
Could
quickly?
we hold for just a minute, Jennifer, and see if there are any questions from the committee members on any of the things you've presented? If you could just kind of scroll your screen back a little bit.
Yep.
A lot of good information covered, and just see if any members of the committee had any questions or comments, follow-up clarification for Jennifer before we move on. Okay, anyone from the general public would like to ask a question at this point? Okay, Destiny.
Hi, this is Destiny with Premier Access. We had talked about the dental hygienist being effective in January, and then with the delay of PRISM moving to April, we understood that that would now be effective in April of 2023. Is that the case, or?
Thank you.
I've
Yep, thank you
misunderstood.
for the question, Destiny. So agree that the alignment of the dental hygienist policy was to occur when PRISM went live. And it is true that our PRISM system is designed to process the claims for this dental hygienist. We are going to allow you to retro bill back to January 1st for any claims that may have been submitted in between that time. So we still want to be able to open the policy on January 1st, but know that the billing for these claims will have to occur after the go live of our PRISM system. So that's something we need to work through with our dental provider community to make sure we're on the same page with that. But that was our plan, was to still allow the policy to go into effect at that agreed upon date of January 1st, but then to allow the claims to back bill.
Okay, all right, thank you.
You're welcome.
Right. Any other questions? Okay, then let's
Thanks,
go ahead and
Michael.
proceed. Thanks.
Yeah, and actually, I'll just say the one last thing I did want to cover, and then I will pass back to Joe. There is one other update that is not policy related, but it is work that the Medicaid program is doing that I'd like to share with the MAC today. And I would just like to compliment Colby for some of her initial work on this, and also the staff at DWS who have committed to do some of this. We have over time received some requests to really help build some tools and resources that will enable members and those who are assisting members in their application for Medicaid to have some resources and tools to help with that process. And at the very bottom of the screen here, I'd like to announce that we are going to be developing both video and step-by-step companion guides that are meant to assist members in their application and their renewals in the MyCase system. These will be developed in both English and Spanish, and will be aligned with the launching of the new platform that will go out in January of 2023. Because that platform is still being designed, some of the design of these materials will have to be completed when that platform is ready. Our hope is to get these materials out in the first quarter of 2023. But I really wanted to share that with this group. I know they've brought this request to us before, and I think this is really important work, and we're excited to get this ready for you. Just wanted to make that announcement today.
Great, very exciting. We saw Stephanie with a nice little celebratory reply in the chat. So sounds like that's going to be well received. That's great. Thank you. And thanks to Colby and everyone else who worked with her on that.
Okay, thank you. And then last, I'd like to just have Joe cover our last policy update on the Medicaid side. Thank you.
Good. Thanks, Jen. And thank you for allowing me to join for a quick plug and kind of an overview of one of the waiver amendments that we made earlier this year. We shared some information back in May about the public comment period that was available for this waiver change. That was driven primarily from House Bill 200 from the most recent session, where we were asked to move away from the open application periods that we had previously used for the medically complex children's waiver and instead allow families to apply at any time. There were multiple reasons for that change, but we have seen a fair amount of attrition on the program. And it is certainly preferred that we're able to enroll families as those vacancies arrive. So we're very excited for this change. There's a few moving pieces that come with the legislation. In addition to the 130 new kids that we'll be able to enroll, we will also start managing a wait list for the program. So that is a little bit different than what we had done previously. So we wanted to make the committee aware, and hopefully you can share with your networks as well, with interested families that we are taking those applications at any time. And previous to our open application process in years past, there is actually a benefit to applying earlier. Both because we are now in this moment where it's a little bit of first come, first serve with both those 130 openings, as well as an additional 100 or so that we've experienced just due to attrition in the last year, but also because the date of application will also become a tie-breaking or a factor considered when families are applying. So if you may be able to assist us in getting the word out, there is some information you can see on the screen. And this is a screenshot of an email blast that went out via our listserv for individuals who are already interested in learning more about the program. But we know that we'd rather have a family that needs these services receive the information from 3 or 4 channels instead of missing it entirely. So if you might be able to help us getting the word out, that would be greatly appreciated.
Okay, thank you, Joseph. And I guess just for members' clarification, this is a program, as you have highlighted there on the screen, where the individual's family members need to go and apply at this website that you have underlined in blue, as opposed to the traditional application process through DWS. Or if they started with DWS, how should they talk with their caseworker about applying for this program if they've already started an application through the traditional methods? Might be helpful for you to talk through, please.
No, thank you, Michael, and great point. And you're correct. For all of our home and community-based waiver programs, DWS will not necessarily look at those as part of the application process there when looking at financial eligibility. There is an additional medical component, a level of care component that we complete. My suggestion would be for a family interested in the waiver services to simply pause the work that they may be doing at DWS and reach out to us, either using the link that's on the screen, or you're certainly welcome to reach out to me directly, and I can share those resources as well. But as part of the application for the waiver, we will also help align with DWS at the point that we're either sharing additional resources in the case the family may not be eligible, or as part of the waiver enrollment, we will assist with the DWS app at that stage.
Great, thank you. Okay, let me open it up for questions to the members of the committee to see if there are any other clarifications or questions in general. Okay, other members of the public in general who have a question? Okay, well, thank you, Joseph. We appreciate the update, and Jennifer, for your report. Before we move on to the next item on the agenda, I did want to just give people a chance to ask questions if they had any about any of the administrative rules that were proposed or any of the state plan amendments that were in your meeting materials that Sharon sent out. Most of the administrative rules are 5-year renewals that are existing rules. But there was one rule where there was a change in long-term eligibility calculations on nursing home monthly expenditures. So if anybody had any questions on that or the state plan amendments? Okay, very good. Thank you. All right, Jeff, and all of the eligibility and enrollment discussions that you have ahead of us. So let's get into all of the details. Let's proceed. Thank you.
Thank you. There is a lot going on in eligibility, as you know, as we prepare for the eventual unwinding of what's been happening since we've been under the public health emergency. So let me start by sharing. I know we gave you a document already. It's called the PHE report. I'm going to share my screen here as I'm talking. Hopefully that works okay. Oh, it goes a lot slower. When there's a lot of people on the call, it goes a little bit slower, doesn't it? Okay. So this is you should have this report in the minutes that Sharon sent out earlier. This is just a graph quickly, and I know it's a little bit blurry there. I apologize for that. It's blurry on my screen too. But it does show the number of people that we are holding open or continuing coverage when we know that they either have not completed a renewal or they may even in some cases not be eligible for Medicaid. Most of which we don't know because they have not done the reviews. We don't know if they qualify or don't, but that number continues to increase each and every month. So we call it forced eligibility, or it's our way in the system of systemically keeping those cases open. You see the large count here of the total Medicaid individuals is the purple line, currently at 518,777, I think the highest ever. And total that are kept open in this backlog kind of condition or forced eligibility or continued eligibility of 246,644. That goes up, as you can see, several thousand each and every month as the pandemic goes on and the public health emergency continues. So quite the bit of activity that needs to occur once the unwinding happens. Now,
Let
over
me
the last
ask a question
Sure.
on that,
Yes.
if I can, please, Jeff.
Sure.
So as I'm looking at that figure compared with, so the purple figure, the 518, as it compares with just the enrollment number that you've reported for September. So for Medicaid's eligibility for September, it looks like it's about 485,900, recognizing there's CHIP eligibility and then the COVID uninsured testing. Even adding all of those up together, that puts us at about 505,000 individuals. And this report showing closer to 519. So I recognize there may be some differences in timing, but how comfortable are you with these overall numbers? Because as I'm just kind of doing rough calculations of the 518 minus the 246, that would put us at an enrollment level lower than March of 2020 when the public health emergency essentially was issued, and even though it took effect retroactively. So I'm just curious, for people looking at this report, how many conclusions you feel comfortable that they should draw, or it's generally a rough estimate of how much work is to be done, because you still need to redetermine the eligibility, but it's a ballpark figure, not here's what the enrollment's likely to look like as soon as the public health emergency ends. Is that a fair statement?
It is, and thank you for pointing that out. I believe the sources here, while they may be the same source in the background, are not the exact same source, and as you mentioned, not pulled at the same time. So that accounts for some of the fluctuations that you're seeing in the background, and I think Brian can speak to that a little bit as well.
Yeah.
Well, Brian, welcome to the public presentation. Let's hear what you have to say.
Thank you, Michael. Brian Roach here. The main difference is that 518,000 figure includes some Medicare cost sharing only individuals for which we only pay their cost sharing groups. We, depending on the report, we sometimes don't include those, but those are individuals that are subject to the MOE. So that's the main difference in the total number there.
Okay, very helpful. Thank you.
And if I could give one more clarification on the smaller graph number, the I guess turquoise, we'll go with whatever color that is. Those cases, they're not meant that those are just the people that have been held open. They are the people being held open in any given month, but people can come on and off that list. An example would be someone that has not completed their review and then later does complete their review. They would move out of that light blue graph bar into the purple group, if that makes sense. So it is a fluctuating number month to month. although it does tend to increase as you're seeing, we are holding more cases open than each and every month. But there are some groups. It's not a complete count of everybody that's ever been held open for any given month in time. So yes, it is complicated for those to show those two numbers. But the point here mostly is it's growing.
Yeah, and the bottom line is you're generally expecting that after the public health emergency ends, that even though Medicaid expansion started a few months before the public health emergency was declared, essentially a year for some populations and a few months for others, your general estimate is that after the redeterminations all take place, that Medicaid could end up at an enrollment level very close to where it was in March 2020.
It's certainly possible. The answer is we don't know. Most of these folks on this list, roughly 80 to 90% of them have just simply not completed a renewal, meaning that we just don't have information. So if all of them were to leave, certainly we'd be back at that number. But there are many that could be eligible still. So the answer is we don't know.
And so for people who are working with individuals enrolled in Medicaid, especially the individuals who may have enrolled in the last few years who have never been in the habit of doing a redetermination application or submitting information, I think this gives everybody a little bit of insight in terms of how much work can be done of continuing to work with that population, make sure if they're getting communications that they complete the information and submit it where, it's not going to impact their eligibility right now, because you're still going to need to send clarifying information before disenrolling them. But to not get in the habit of just disregarding those requests for information would be something we would like all of our communities to start taking more seriously over the next couple of months.
And a beautiful segue to where we are in time. We have this last week received what we think may be our last renewal for the public health emergency. Nobody knows. I don't know. I have no insider information. We were extended until January 11th. This has happened every 3 months during the course of the public health emergency. So it's a normal event for us. There is some reason to believe that we may get our 60-day notification, which has been promised from CMS and from the federal government to let us know when the end date would be. So we're very carefully watching November 12th, which happens to be a Saturday. November 11th is a holiday. So November 10th and possibly through the following Monday, we'll be watching that weekend to see if we indeed get that promised 60-day notification. And when that occurs, your message is right on, Michael. We want to make sure that not only you keep your information up to date with us, but that you know your review date, that the families are aware of when their case is set to review. And this will sound a little strange. We want them to wait in line so we can get to them. This is a 12 to 14 month process to get to everybody. We're reviewing all cases, not just those that were held open. It's all cases over the course of 12 months. And so the message is, don't call us right away. We know you're in line and we want to make sure we get to you, but please interact with us and Workforce Services at the right moment in time. So the messaging will change quite a bit, I think, at that 60-day notification. Under this scenario that I'm using right now, if it were true that the public health emergency ended on January 11th and we were told in November, Workforce Services would begin to look at cases and start reviewing cases, as you're pointing out, on December 1st. So we would look at on December 1st, we would start the renewal process for our first batch of cases, the first 12th of the cases. And any closures that might occur or moving to, for example, moving to CHIP, that kind of thing, would start to occur at the end of January of 2023. So that's under that proposed timeline. There are those that would suggest that this timeline is completely inaccurate. It may go all the way into July of next year or some other time. We don't know. We've tried to push CMS on this issue multiple times and they don't know. So we're doing the best we can and preparing and getting ready to run the race. But if the gunshot doesn't occur, we will not start the sprint. It's better a marathon. It's going to be a 12-month experience. So we're getting ready to go and we're getting warmed up and we think we've got everything in line, but it's a wait and see approach. I did want to point out Utah is one of 2 states initially and now 4 or 5 states that has done, according to somebody else, and so I'm going to pat myself on the back, they're saying that we're doing a pretty good job with transparency. And we have moments like this today speaking in the MAC, but I'll just quickly show their chart because it's a fun graphic. Originally, it was Michigan and Utah were the first two states to be, based on their criteria, these 6 elements, making sure that we were being transparent and showing what was happening in our state around the unwinding and what's occurring. So that's great kudos to us and to Michigan. I guess a little bit less for Wyoming right now, but hopefully they're working on getting things a little bit better. Back to our chart, we are in the process of asking CMS for some additional flexibility that will allow us to do such things, for example, as increasing the time that we have to respond on a fair hearing. So if someone's case is closed and they want to file a hearing, they can do so. This gives the state a little bit more time to respond to those hearings should they be overwhelmed with the number of hearings and that type of thing. There are a couple of others that allow us some flexibilities on how we receive or how we take the address off a return to mail, for example, and can update that more quickly. So we are seeking some of those flexibilities, and we'll update you on whether any of those were approved as we seek those over the next month. And as always, if you want to look at our unwinding site, it is medicaid.utah.gov/unwinding, or off the main page, there's a link to unwinding, and you can see all of this information and more and read our plan, et cetera, and see what's going on. So let me pause there on those dates and on unwinding in general, see if there are any questions. Hearing none at this point. Michael, would you be okay if I took the next 2 items out of order and talked about the proposed the reopening of the comment period for the second proposed rule?
Yep, that sounds fine.
Thank you. I'm going to jump to that next. This one is an interesting one. So as you're aware of the Families First Coronavirus Act, I may take you back in time. In March of 2020, that was approved very quickly, and we did something we've never done before. We called Workforce Services and asked them to push the magic button that kept cases open. We, of course, don't have that button, had to figure out how to get that done. And the guidance originally was not great. It was keep people where they are right now, boom, just stop where you are. And it did things that were uncomfortable for us. For example, a pregnant woman who gave birth in March was kept on pregnant woman Medicaid all the way through, I believe it was January, February of the following year. And things like that. Or we had children, for example, that were turning 19 and should normally move on to a different Medicaid program, and were staying on child Medicaid. So CMS quickly realized that and changed the rules it was about November of 2020, which we quickly implemented in January, February of 2021, and started, as you saw in the graphs of over time of the pregnancy, is a great example of that, where we started to see the pregnant women move from not being held as pregnant forever and moving into other programs. That structure is called the tiers, T-I-E-R, not tears as in crying, which is what some of us may be doing as we're looking at all of these cases over 14 months. But it caused a tier structure. And there was a problem that we didn't recognize at the time, or didn't understand maybe at the time. And I'd like to talk about why that original law, the FFCRA, or FFCRA, or Families First Coronavirus Response Act, is being reopened so that people can comment yet again. There, in that tier structure idea, I could move a pregnant woman as an example. She's receiving full coverage. I could move her over into our adult expansion Medicaid program and get the same type of coverage. They're considered equivalent coverage. That's a good example of someone that might move there anyway. There were some cases where it was not friendly to some folks. For example, if I had Medicaid and Medicare, and my income had increased, we could move that individual to a qualified Medicare beneficiary program, and the Medicaid could end. And that was permissible under the new tiers structure. CMS recently has had a lawsuit filed against them for that activity, meaning that the original law, as envisioned, some believe, it says that you must keep the cases open as they were at that point in time in March of 2020. Here is a timeline, a hypothetical timeline of what may or may not occur. The top of this graph being what is happening with this particular rule, and the bottom half of the graph running on those dates of the public health emergency we just described a moment or two ago. So on 27th of September, the comment period for the FFCRA law has been reopened and will close on the 27th here in a week. The reason, again, for that is that there was a lawsuit filed against CMS at the federal level. They are now reconsidering if they should, in fact, return to the pre-tier day. So this would be prior to, so the March 2020 rules would then apply to us in the Medicaid realm. They have not described how we would do that, when it would apply to us. Is that prospective? Is it retroactive? Or is it to certain groups or programs? They've not described what that might look like. But they have described that this activity is occurring, and I think are looking to try and rectify that to protect themselves from a lawsuit or having some action taken against them at the federal level. So understanding that timeline and knowing what that could mean to Medicaid, just so you're seeing this here, if they took the month of November to think about the comments that they're likely getting from states and others on what that could mean to us, they in December are anticipated to give us some type of information on what we would have to do and publish a final rule. And we would anticipate perhaps in January having to do something with those cases, whether that's retroactive, whether it's to certain programs, or whether it's to all cases, and trying to return them to whatever they were in our case, in our states, prior to January of 2021. That would be an immense activity by itself. On the bottom line, you're seeing those dates we talked about with the public health emergency. Those dates are running concurrently, and that would put us in a traffic jam that would be unprecedented, to say the least, in trying to figure out what to do in the month of January. So as that comment period is open, they are entertaining comments, again, from you and from the state to comment on what that might mean, whether that's a good idea, a bad idea, etc. And we encourage you to take a look at that particular rule. And again, we're taking these out of order. So if you're following the agenda, this is the second rule, and it says under there that it's been reopened, if that's helpful.
And so to just clarify or maybe raise some awareness for people listening, if CMS chose to make the changes that they are proposing in the notice with comment of the final rule and make them retroactive, the Utah Medicaid and other Medicaid programs would potentially have to go back and review which original eligibility the individual was enrolled in, and if they had a differential benefit package for the past 2 years, would maybe have to cover services that hadn't previously been paid for. So this could affect the agency and providers' coverage for the people possibly having had a benefit denied based on their eligibility category. Could involve potentially additional payments for dental managed care plans, the ACOs, in a number of ways, just not really knowing how this could potentially happen. And a lot of complexity as you, as the agency and DWS, would have to go through and try to recreate an eligibility history. So a lot of burdensome administrative processes could offer some additional benefits to individuals that didn't have them. I don't know that you have a great estimate right off as to what the impact would actually be, but in terms of those who are on the call who might be interested in commenting on the proposed final rule, or the final rule with comment, that might be something to generate some additional interest for people. So we just wanted to bring that before the MAC and have people aware of what's going on there. So thank you for that. And we'll let you move on to the other proposed rule.
Thank you. And as you can imagine, as we've talked to, I think Workforce Services won't let me in their building anymore. As we talk to them, you probably noticed Maurice even squirm on this call alone. This is a lot of work that would be coming at us at a very difficult time to try and rectify those things. And it's not that we don't want to help the folks that need to have that fixed. We're happy to go back and perhaps fix those cases that need that extra benefit given, but it would be at a very difficult time to do so.
It's just very difficult to keep changing the rules of engagement for administrative agencies and trying to figure out how you're supposed to. Very much understood.
Yeah, I guess one comment.
Yeah.
One comment we can make: future changes are not that difficult to make. It's reviewing all those decisions retroactively that we've made. That might spell, at this point, I don't even know how we can do that operationally. And I think we'd really have to put our heads together outside of, reviewing every medical decision we have made in the past year and a half. And there's been a lot. So moving forward, I mean, if this is the change that we have to make, it's not a difficult change to make. It's reviewing all the past decisions that we really worry about.
Yeah, you can just push that magic button prospectively that Jeff referenced, but I know retroactively it's a big lift for sure.
And it's a little unfortunate in a state like Utah that's been very compliant and moved with the changing rules as they've occurred. We've done so. It's interesting to me to note that there are some states that have held on that first set of rules and really are still open as if it were March of 2020 and never implemented this tiered structure that we were asked to do. So we're almost penalized for doing what we were asked to do in this case. Wonderful. Let's move on to the third piece that I have today, which is a summary. And this is not the only summary. And let me start with, this has not yet been shared with you, but will be right after this call today. There was work being done on this, I think, even up to last night. So this is not the one and only summary of this proposed rule, but bless CMS's hearts, they're not done with just talking about the unwinding. They have lots of other things on the burners, apparently, to do for us. This was a little bit of a surprise to some of us that 300 pages of new proposed rule were released just on September 7th. And this is a summary, a 13-page summary of what some of that will do to the state of Utah. Happily, there are moments in here where we found that we're already doing some of the things they're asking states to do. There are also some moments in here where we're thinking, well, gee, how will we do that? And we've tried to break this down into a digestible format for you to at least get a highlights or high-level view of what this rule may mean to us. And very quickly want to talk timeline. I think that's important with this particular rule. This one is also out for comment, and I believe is good for another to November 7th, if I'm recalling correctly. So as this is out there, please, if you're looking for things to keep you going to bed at night more easily, there are 300 pages of this, and it's good stuff. On the implementation timeline, this one will become effective, and CMS will not become effective right away once it goes through this process, and then not be really followed up with or followed up upon by CMS for 12 months. The concept there is that this would allow us to get through the unwinding period and not have to be making changes to our eligibility system midstream. So that's the concept behind it. So the timing is a little bit different on this one. At least from past rules we've seen that usually take effect right away. But that is an interesting moment for us. There it is. We did have the date. The comment is due by November 7th. Someone just has to remind me to scroll it from time to time. So what we thought we'd do, and again, there are other synopses of this out there in the world that you can look at. I think almost everyone's producing one or another now. Again, I think if you want the detail, it's best to go into the rule itself, which we have referenced here. If you click on that link, you'll actually get to that 300 pages of fun. But we tried to bucket into the same different, there are 4 different objectives that CMS talks about. And so we've tried to bucket this in that same way. And I probably should have prefaced this. I, Jeff Nelson, have not yet read all 300 pages. I also was not instrumental in putting this together. I want to thank the staff that did put this together for us. Michelle Smith, I know, is on the call and did a lot of work to pull this together and make sure that this happened for today's meeting. I don't want to be taking credit where it's not mine. On the objectives, there are 4. The first is, as you're seeing, to streamline the application and enrollment process. The second is to improve retention, to make sure that we keep the folks that we have, those retention rates at and between the renewals. The third is to remove any access barriers for children specifically. And number 4 is to enhance program integrity. So there are 4 different buckets, if you will, of concepts here. What we thought that made the most sense for us anyways was to try and give you what we are currently doing. So we will give you, they're numbered for clarity, hopefully that will help. So for example, on this one, it's facilitate enrollment into Medicaid cost sharing programs using Part D low income subsidy data, a program that a few of you know something about and most of you may not know much about, but there are some folks that are referred to us. We get a lead, if you will, from people receiving a low income subsidy, and that information is passed to the state of Utah. We then open up Medicaid for them. And that's what is spelled out in that current. So on all of these, we tried to put a current section of what's happening now, and then what's proposed to change. There's some effort here to try, in this case, of this particular item, to streamline that enrollment for some folks, because some of the requirements under LIS are not the same as Medicaid in the states. So we have an opportunity to streamline that. If we can align those programs better, it would be a 1-for-1. If someone comes on this LIS lead, we know that they do qualify for Medicaid because it's 1-for-1. So there's some impact to Utah. In that case, we tried to say or call out what that impact would be. So we do use the LIS data today, just for those that are curious. We do take those leads today, and we do make that into an application, but we'd have to modify some of our policy and procedures to make sure that we could do this better under the new proposed rule. We took that same approach with a multitude. This is page 2, but there are up to 13 pages of fun here. Many things like this. And we tried to really indicate, if we could, that if it had no impact to Utah, but we really were focusing on those that did have impact and what that might mean for us. We should also point out that this is a summary, and summaries are very difficult when you're taking that much information and content into a short period or short item here. So please, if you're interested in these, look at the actual rule to see what it's saying there. And in some cases, as we talked about in the last hour in the chip pack call, there are some areas where even with the 300 pages, it's not enough detail to really tell you what it means. We'll have to wait until the final rule is finalized, and CMS can give us the guidance or the technical assistance on what they actually want us to do in those circumstances. So with that, we did, again, try to bucket these together. I'm just going to scroll through a little bit. I'll try to do that somewhat slowly for you. I know that's hard on some folks to do this. I'm sorry about that. I wanted to point out this one, number 6, which is a verification of citizenship, as an example, where it says what we are currently doing today to verify U.S. citizenship, what the proposal is, which is to treat verification from the state's vital statistics system, which is housed in the Department of Health and Human Services. SAVE is a system that DWS accesses electronically to validate that information. And if we do so, you can take that as evidence of their citizenship. Well, this is one of the cases where we do this today. So we marked that indication here, or we tried to indicate that here for you. So hopefully this is a document that will give you, again, if you're looking for those moments of sleep, or if there's a certain area of interest that you have, hopefully this will drive you to the right area of the 300 pages and at least give you a taste of what's in there. But this is a summary, as indicated. There is a lot to read and a lot to understand in there. Again, not having done that myself yet, we'd have some people on the call today. If there's something specific that you are aware of or wanted to talk about, we can do so. Again, this is not currently in your list of materials, but we are sharing this with you through the MAC channels right after this call today or shortly thereafter, and you'll have a link to this document. With that, any questions? Thanks, Stephanie. I'll continue to scroll if something catches your eye.
This is a great resource. I think it's just kind of given us an overview, and thank you, Michelle, and the rest of the team for helping put it together. As much as Jeff made the presentation, I know Michelle's very envious about missing opportunities to present the data, so we might have her come back for an encore performance if she felt like she didn't get a good vetting of the material. But
she would love it.
Yes. But if you, after we make it public, so I think we can have Sharon send it out, but we'll also post it on the MAC website so that people can access the materials and go through it. And it really does a nice job of providing some detail about what the proposed rule would do, and recognizing there will be a comment period into early November. If you'd like to comment on it, you can go to the website highlighted at the top of the document, and then we'll have to wait and see what CMS chooses to finalize or not. But some of the issues in terms of when they would be implemented have an immediate impact as soon as the rule would go live or be finalized, and others have more of a delayed impact. So some of those things would be interesting for everybody to be aware of. So thank you for putting that together, walking through that with us. Let's just see if there are any more questions that people may have had, as they may have had a minute to think about it. Okay, Maris, do you have any other comments that you would like to add to any of this material?
No, I'd just like to ask the group to quietly pray for us as we as we move forward with all of this.
Okay, it's a genuine petition, so we'll put that out there. Very good. But thank you and your staff at DWS for all the work you've been doing, trying to determine as best possible what type of impact it will be going forward for people being disenrolled. And yes, you do have a lot of work ahead of you. So I think we are thinking about you for sure.
Thank you. We'll continue plugging along. And I just want to give a shout out to our partners over at DHHS. We come to a point where there's a great understanding of the work and the difficulties that we face over it as we try to administer ever-changing rules. I think that partnership makes all of this easier. So just a shout out to them as well for helping us along the way.
Great. Thank you. That's nice. Thanks. Okay, well, next we do have on our agenda the committee member updates, but before that, let me just see if Cassidy's had a chance to figure out his connection and if we can have him introduce himself to the MAC.
Yahweh, everyone.
Very good. That is great.
Can you hear me now?
Yes, we can. Thank you.
All right. Thanks for having me. Cassidy Matthew. I'm currently working with the Micronesian group, Pacific Islander, Marshallese mainly, and people from the Micronesia here in Utah. So I'm honored and thankful to be part of this. One of the things that we really struggle with is this one, Medicaid, especially here in Utah. For folks from people from the Marshall Island and people from Micronesia, that's one thing that they really struggle with is Medicaid, either enrolling or being denied or being rejected. So I'm hoping that with these meetings, I'll get those information that the public will need them from me, then I'll pass it along to them. So again, thank you. And I'm hoping to learn as I'm, picking through all these meetings. So thank you.
Thank you, Cassidy. We're very excited to have you join the MAC and have your perspective as we talk about different things and how it might impact some of the populations that you represent. And you will be very maybe interested to know that on number 5 on our agenda, we'll be talking about how to do some constituent affairs and how to get feedback when people are having some challenges. So hopefully that will be helpful, but it'll be an ongoing process where we can hopefully have the committee and the Medicaid agency provide information to you and the rest of us. And then a lot of times we can share information from our different perspectives that can be helpful to them. And I think as we start talking about this Medicaid eligibility unwinding, trying to see what you can do to help share this message with your communities about when you get communications from the state of Utah asking for updated information, how important it is for that information to be completed and submitted so they can maintain their eligibility. So great opportunity for us to work with you. Thank you.
Thank you.
Okay, next we have committee member updates. So this is a time in each of our meetings where we just open up discussion to any members of the committee who have something that they've experienced or an item that they would like to discuss, problem resolution to bring before the agency or the rest of the committee to discuss. Stephanie, please.
Hi, everyone. There's a lot of background noise because I'm outside walking, but I just wanted to say that we are so excited about the Medicaid member meetings that we are trying to do every month. And I just wanted to say how much I appreciate Jennifer for prioritizing listening to members and just there's a lot of reasons why sometimes engagement is low in different ways, whether it's in healthcare or in just like asking for things to be different. But I'm just really, really grateful for the effort that Jennifer and her team is taking to listen and to try to make things better. So thank you. And I'm excited to get the subcommittee started for the members, for the member perspective on the MAC and see if we can make some progress. So thanks everybody that's helped to kind of promote and support it too. I just wanted to say thank you.
Very good. Thank you, Stephanie. And if anybody's interested in participating in those meetings, what's the best way if they aren't currently aware of the member feedback meetings to participate in those?
For the subcommittee or for like the Medicaid member ones, like out in the community?
The Medicaid member ones, yes.
So the subcommittee is going to be like public. I believe that's like the rules, and I think that's fine. But then the community ones, they're open to anybody. It's just like we're doing our best to like get the outreach out. But I think I saw a comment in the chat, I think from Rebecca. So Rebecca, let's connect and we'll make sure that we can increase like opportunity and access to those. So I'll reach out to you if you want to put your email in, or I can put my email in the chat and we can connect on that.
Okay. Yeah, that sounds great. And then maybe if we could have Sharon send that out in our follow-up meeting materials in terms of just how to participate in those meetings for those who may be joining this call and not previously aware of how to participate there. Okay. Very good. So get that. Any other committee member comments, updates? Very good. All right, then next we're going to move to item number 5, Medicaid Constituent Services and DHHS Customer Experience. We're going to first have a presentation from Tracy Barkley, and then Donovan Bergstrom will present after her. And we'd ask to save the questions until after both presentations are complete, and then we'll go through questions at that point. Tracy?
Thank you. Sorry, I got to get the mute button, right? All right. I attend these meetings monthly, and I'd much rather be an attendee than a presentee. So are you able to see my screen?
Not yet.
Not yet? Okay. Let's try again. How about now?
Yes, there we go.
Okay. So I wanted to introduce myself. I'm Tracy Barkley, and I'm with Constituent Affairs. I'm with the Department of Health and Human Services, and I'm actually in the Division of Integrated Healthcare. In my position, I wear many different hats and have many different responsibilities. But what I wanted to let you all know is, what my core responsibilities are that you would be interested in knowing. So, for example, I answer eligibility and benefit questions. I help connect people to resources. And the main thing is I help resolve complaints and concerns and do that in a timely manner. So for myself, I have my own expectations and goals. And the first thing is so people can call me, and I find it a lot easier to answer a call versus answering a voicemail. So that's one of my high priority is to answer the call, when I can. For example, right now when I'm in a meeting and I wouldn't be able to do that, but I always return a call within 1 business day, and actually 99% of the time I'm able to do that. I answer questions and address issues that individuals, which can be members, providers, the public, contact me regarding. Sometimes it's just providing redirection to the correct area. Most of the time it's identifying what the main concern is and working to get a resolution about that concern. And just as information, I receive approximately 170 calls per month, and that's a statistic over 6.5 years. And I do track my calls in a system and, like I said, track them to resolution. Sorry, I'm having a problem with that. Can you see it? So I wanted to start out with examples of what types of calls that I can handle, because I get all sorts of calls. My favorite is someone asking me to change their airline reservation. So, but it's with Medicaid and CHIP, it's usually an escalated complaint or concern. So, for example, a member is denied eligibility and they don't understand the denial. Or if they're frustrated with the application process, maybe they just need some explanation of the application process and what the steps are. If a member doesn't understand eligibility policy, I try my best to explain the Medicaid policy in terms that hopefully they can understand, because we all work in the policy and Medicaid area every day, but they don't. So I try to make it to where they can understand it. Another example is a complaint regarding finding a provider. Maybe it's just connecting them with their Medicaid health plan so that the Medicaid health plan can assign a case manager that can assist them with these things. Or if they can't obtain a service, or if the provider, for example, cannot get a claim paid. And then I also accept grievances from about the health plan or the prepaid mental health plans. So some frequently asked questions that it's usually just a matter of explaining to the individual and redirecting them are, what is the status of my application? What is my spend down amount? When is my review due? I can give them that information, but then I like to redirect them and explain, this is Department of Workforce Services is who you need to work back with. Another is, what is my eligibility status? And they can call the health program representatives to find that out, or they can create an account on my benefits. .utah.gov to check their status each month. Or some people want to know, what's my Medicaid ID number? What's my health plan? What providers can I see? So each of these areas, they have a starting point. Like I said, maybe it's Department of Workforce Services with their eligibility, or it's the health program representatives. But if things escalate above that, that's the type of calls that I receive. And then I just made a resource for you about just who to contact as an example, so so that you have that information. Did you want me to go through each of these, or
No, I don't think we need to. I think maybe we'll just let people know that if they haven't looked at the meeting materials that Sharon sent out yesterday, that both Tracy's presentation and Donovan's presentations were included in that. So you can open that email and have all of this information. But a great resource just in terms of a grid, if you can identify type of problem that Tracy's identified the path of most direct resolution, I guess I would say. So that's great. Thank you.
You're welcome. And then I included my contact information. Thank you for this opportunity to be here and to present that information.
Thank you, Tracy. We really appreciate that. You do a lot of great work for a lot of people, but I think sometimes there are others that don't know about you as a resource, and this will be very helpful for a number of people, I think. So now we'll turn it over to Donovan and see how this fits within the whole department's master plan for continuity of care across multiple programs and his role. So welcome, Donovan. Thank you for being here.
Well, thank you for the invite, Michael. My name's Donovan Bergstrom. I'm the director of the Division of Customer Experience, which is a brand new division for the Department of Health and Human Services. And our vision is that all Utahns will have a first-in-class customer experience when engaging department services so they can thrive in their homes, schools, workplaces, and communities. Right now, we have a goal of increasing customer voice, and we're looking at doing 2 current projects that address this customer voice focus. The first one is a digital concierge intercept tool So basically, that's a fancy word for a feedback survey on websites. And this was a partnership that we started with the governor's office several months ago. And then we also have a customer experience journey mapping project that I just started in the last couple of weeks. Michael, I want to be mindful of time. Do you want me to present what I sent Sharon, or do you want me to do a quick overview since all the participants have the information about the digital concierge?
Yeah, I think since we have the survey questions and kind of that overview as a resource, if you could just kind of spend whatever time we have here, the next 10 minutes, just kind of talking about how your group interacts maybe with Tracy's group, and just an overall viewpoint of how you see your office interacting with Medicaid patients, providers, et cetera.
So sure. So the first thing on that digital concierge, we're looking right now for the department. We have this tool on 10 different websites that for the department right now, and we're looking at adding these to other websites once they get updated with our new logos, new colors, due to the merger. This will provide us feedback on the website on what was the effort for people who are going to our website, what was the satisfaction, were they finding what they wanted, and also there's some questions on trust in government. And that is a initiative from the governor that we have taken on for the Department of Health and Human Services. And it also has this digital concierge has a feedback loop where somebody could go on to that website and say, I wasn't finding this, please contact me. And this is where that information would be sent to Tracy and with constituent services, where she would follow up with that person. And again, it would be whatever this person was looking for. And Tracy, is very skilled at, finding or linking people to the right places based on what their concerns are. The other thing with the digital concierge, this is a first step in a customer experience pilot program with the governor's office. And this is the crawl phase, they call it. We will also have an opportunity to be more specific on some of the questions that a operational unit may want to ask in this survey, and be able to use that for other pinpoint surveys if the operational unit would want that. And so I know there's already a lot of surveys that are going out right now for your constituents. And the one thing nice about this digital concierge is that it is a immediate feedback. We're getting this right away. And so we have data that comes to us quickly that we can review. For example, some other agencies have used this information and made changes within a couple weeks just on their website, with people having problems accessing certain things that they needed. So that's the goal, at least right now with this first phase of the digital concierge, is a good feedback tool for people who are coming to our website. This may or may not be a client, a Medicaid client, but it is somebody who is just coming to the website to begin with. The other thing I just wanted to talk briefly about is this customer journey mapping. I've identified a few programs within the department, and later on, I would really like to do a customer journey map of the Medicaid intake process from the customer's point of view. And what the journey mapping is, it's a customer map and a visual representation of a customer's processes, needs, and perceptions throughout the interactions and relationships with an organization. And customer journey mapping helps an organization understand the customer journey from the customer's perspective. So not from the system perspective, not from their partners, but from the customer's perspective. And the goals and objectives that we would have for this is to provide customer experience feedback that will allow the department and our partners to be more responsive to our customers' needs, identify best practices and improvement opportunities that will increase positive customer outcomes. And the last thing is to build that public trust and efficiencies in the department. And so there'll be further discussions about, with Jennifer, with DWS and other stakeholders on this journey mapping and what this could look like. But we wanted to present, a couple opportunities where we're really looking at improving our customer voice to this committee. So Michael, that was a quick overview because I'm anticipating there's questions for me.
Okay, now that's great. So if I can just summarize, individual constituent affairs issues, Tracy, or the resources she has pointed to, and you're looking more, how well are we doing as a system, as people come into the system through whatever avenues, evaluating potential opportunities for improvement, looking for feedback where you can clean up big picture systems and communication pathways, and see just systematically how the agency can improve as it engages with the members of the public. Is that a fair delineation between the two?
I think you did an excellent job of a summary. Thank you, Michael.
Okay, thanks. All right, to the members of the committee, any clarifying questions or additional thoughts you would like to share, ask, anything of Donovan or Tracy? Okay, members of the public in general participating in the meeting, any other questions? Okay, well, some great resources available. We appreciate your presentations and the information you've shared with us. It's nice to know that there are opportunities for feedback as people navigate the system and people to help kind of cut through the difficult chains of bureaucratic pathways to try and keep it simple sometimes and just know how to get answers to questions. So we appreciate the role both of you do and appreciate you coming and presenting to us today. And thank you for your time.
Well, thank you.
Okay, next we have a budget overview from Eric Grant. Every year in October, we like to have Eric come and present about where our fund balances are, how we closed out the fiscal year, and answer some of my questions. In particular, I seem to be really interested in this realm. So
Absolutely.
Take it away, Eric.
Absolutely. Happy to do it, Michael. All right. So yeah, as Michael mentioned, we're going to talk about where we closed out our fiscal year and what the fund balances look like in particular funds. And we'll talk a little bit about what funding we had lapsing, non-lapsing, and some unusual new circumstances that happened this year. So we'll just jump right in. We'll start with our Medicaid administration line item. So in state fiscal year 2022, we were still under our old structure prior to the merger of the Department of Health and Human Services. So we had separate line items for our administration, for Medicaid services, and then for the Children's Health Insurance Program. With the merger, those will change somewhat. We will still have a line item for administration, but it'll be larger than just Medicaid administration. And we will still have a line item for services, but it'll include both Medicaid and CHIP services, along with some other items. So it'll look a little bit differently in future years. But anyway, back to the topic at hand for 2022. So here's where we closed out with our Medicaid administration line item. As you can see at the bottom, it shows our fixed funding, which are our appropriations from the legislature and other items that are kind of constant. That's why they're referred to as fixed. Our revenue, which includes our federal funds and other sources of intergovernmental transfers. The expenditures are in EXP is what we spent. And then lapsing are the funds that went back either to the general fund, or sometimes lapsing funds could be where we're lapsing authority. And what that means is we were appropriated money, but either that money wasn't available to use, or the circumstances around that appropriation didn't come to light, so we were unable to use that funding. And then finally, we have non-lapsing. This is money that gets to retain with the division that we can use in a future year. Now, oftentimes, a lot of non-lapsing items are very specific, where we only can use the funding for a specific purpose. But due to the public health emergency and a lot of the unknowns around the unwinding, we had the ability in state fiscal year 2022 to non-lapse anything that was remaining. And so that's kind of an unusual circumstance, and that explains why our non-lapsing balance was at around 3 million. So any questions on the administration line before I move on to the services line? I am seeing none, so I will go ahead and move to the next line. Okay, this is the exciting one. This is where most of our funds go, as you can see. So I want to focus in particularly on the lapsing and non-lapsing here. Those balances look, fairly large, and there are reasons for that, and I can explain those. So within the lapsing funds, there are three main items that make that up. The first one is what we call our buffer appropriation, which we go through the consensus process with the governor's office and the legislative fiscal analyst. And our attempt is to try to come as close as we possibly can to predicting how much Medicaid is going to cost over the year. It's very difficult to predict that right on. And so they appropriate us restricted funds, and in this year it was about 21.7 million that we can use in case we go over budget. And we can use them in either the Medicaid or the CHIP line item, and that same 21 million was appropriated to both line items. Since that didn't happen and we didn't go over budget, that funding lapses back to the general, or to the Medicaid restricted account. There was 8.2 million in authority from the hospital assessment fund, which we didn't use because we didn't collect it and we didn't need to use it. And then finally, there was 67 million additional funds in the expansion fund that we had authority to use, but because we didn't have expenditures related to Medicaid expansion to support those, we did not use those. Now, the non-lapsing, this to me is the more interesting piece. And I actually have a slide on this as to what caused the non-lapsing. So we had 105.2 million non-lapsing funds. 79.6, the large majority of it, was our ARPA carry forward, and I will get to that in just a moment and explain that a little bit further. 8.5 million was for the PRISM project, which you're all familiar with, which is our new system implementation project. 1.3 million were intermediate care facility for the intellectually disabled, quality improvement funds that are carried forward to be used in the next year. 500,000 for application security and redundancy. This is funding we can use to help maintain our systems. And then finally, we had 23.7 that non-lapsed due to that provision for the maintenance of effort that I mentioned, where the legislature said, if you have any money left over, we'll just leave it in your budget. So to the ARPA carry forward. So ARPA was a federal law that passed, and they had an interesting provision for Medicaid. They allowed the division to draw an additional 10% in federal matching funds, but for expansion, it was reduced to 5%. Now, we were able to draw this funding over a period of 1 year. So it was from April 1st of 2021 to March 31st of 2022. And we were able to draw it on these three basic areas, which were home and community-based services, behavioral health services, and school-based skills development services. So that was the sum total. The 79.6 is the sum total of that amount we drew in excess federal funds. Now, there were two simple requirements on it. We were able to draw those funds, but we could not supplant any existing general fund, meaning that we couldn't use those to reduce the appropriations to the Medicaid program from the state general fund. We have to use that funding to actually supplement the program. And so they've given us till March 31st of 2025 in order to spend that money we've drawn down. So we've got several projects that the Department of Health and Human Services have put forward in order to spend that funding. The first one is a temporary 5% supplemental increase to those provider groups. So for home and community-based service providers, behavioral health providers, and school-based service providers. Other projects we've put on the table include institutional diversion activities for individuals on the HCBS waiting list, which is basically trying to provide some services for people who are on those waiting lists to get into the HCBS waivers. We've included some funding to convert existing ICFID facilities into home and community-based settings, and one-time funding for infrastructure grants. So with that, I'll ask, are there any questions on the program line or on the ARPA funding or projects? Okay, I'll move on now to the CHIP program.
Eric, this is Brian. Sorry.
Oh, yeah, go ahead, Brian.
So these are all proposals, right? These are all proposed things that you're looking at.
So with the ARPA funding, they were proposals. We've run them by legislative leadership and have gotten them approved, at least those items with CMS. There are still some other projects we're considering that we have discussed with the legislative leadership and are in the process of discussing with CMS.
Okay, great.
But the 5% supplementals have been approved, and those have been going on, and we paid them actually retroactive back to April 1st of 2021.
Okay.
Any other questions? Okay, so the line item for the Children's Health Insurance Program, as you can see, it has actual expenditures have gone up, and the lapsing funds went up as well. Non-lapsing was at about the same amount. And again, the source of that lapsing funds in this line item was the same 21.7 million buffer that I mentioned earlier on the services line. So one of my interests for Michael is the Medicaid Expansion Fund, which is, this is the fund that was created with the Healthcare Improvement, or I believe it's called the Healthcare Improvement Act, but I could be mistaken in that title. Basically, this is what helps fund Medicaid expansion. As you can see, there are some appropriations every year that go in through general fund, but other sources that make up the revenues for this fund. And then the expenditures that come out, you can see in the next column. And right now we're at the close of state fiscal year 22, we were at about $199.3 million balance in that fund. Finally, or sorry, any questions on the expansion fund? Okay. Finally, the last thing I want to touch on is the Medicaid enhanced match due to the maintenance of effort. So with the public health emergency and with Medicaid being required to keep people open on the program, the federal government allowed us to draw an additional 6.2% in Medicaid match. And so this chart just shows the actual dollars that we collected as a state in that 6.2% match. Now, the difficulty here is to try to understand that, as Jeff kind of pointed out in his presentation, we're not sure how many of those people being held open will remain open. And so it's hard to say, were we, how shall we say, profitable, or did it cost us money due to the maintenance of effort? We really don't have a good idea. Our best projections are that the 6.2% match that we did draw was greater than what it cost us to hold those people open. So any questions on the enhanced match?
Yeah, this is Brian again, sorry. So this potentially will go away at the end of March?
Yes, exactly. If the public health emergency ends on January 11th, we will be able to have that extra 6.2% through the end of March. So okay. The actual rules are, it'll end the quarter that the public health emergency ends.
And so in terms, well, let me just ask this question. And in terms of your budgeting for the current fiscal year, when you came out of the legislative session, how far into this current fiscal year had you assumed the public health emergency would run?
So when we did consensus in February, we assumed it would end on June 30th. The funding, the 6.2 would end June 30th. So we're going to adjust that in our October consensus My hope, and haven't had discussions with governor's office or the legislative fiscal analyst, is that we will project it ending March 31st, or the funding ending March 31st.
Sure, because that's all you know for sure, but that at least gives your budget 3 quarters or 9 months of additional enhanced match, so that you don't currently have in your budget.
Correct.
Okay. All right. Okay, looks like Andrew Riggle has a question. Andrew?
Thanks, Michael. Hi, Eric.
Hi, Andrew.
I was just wondering, we have been talking to a legislator who is looking at the expansion fund as a potential source of funding for initiatives that they have in mind. And I can't remember off the top of my head what the money in that fund can be used for. Can you give me a quick summary?
Oh boy. So that funding,
or not.
Yeah, no, the funding is mainly intended for the Medicaid expansion population, and it was created for that purpose. Now, being that the legislature has that capability, they can actually appropriate funds out of that fund if they so choose. But the intent of that funds is for Medicaid expansion and that population.
And particularly for the expansion population itself.
Correct.
Great. Thank you very much. I appreciate it.
Yeah, and sorry, this is Brian Roach. I'll also add that any change would have to be changed in code, in that it's section 2636B. So yeah, I mean, we've become aware over the months that some legislators are interested in using those funds for other purposes, but it would require a statutory change to allow that out of the expansion fund.
Okay, great. Thank you for the additional piece, Brian. I appreciate it.
Mm-hmm.
Okay, any other questions? And then I've got a couple more. Okay. So one question I have is, how much money is now in the Medicaid restricted account? Because the balance as of fiscal 21, it had $40.9 million in it. You mentioned like $21 million was put into your budget for flexibility, and then you didn't spend that. So where is the Medicaid restricted balance at?
So I haven't done an analysis on that, Michael, but I would imagine it's the same place it was last year, because typically, as you well know, when Medicaid lapses funds back, they flow to the restricted account. But due to the maintenance of effort, they've allowed us to retain those funds. And so the only thing that would have lapsed back would have been that 21 million that they appropriated out of the restricted account.
Okay, so it should be back to 40.9 million. Okay, and then what about the Medicaid growth reduction and budget stabilization account?
Oh, that one I do know. I don't have it off the top of my head, but I'd be happy to send it out to you and the members of the MAC.
Okay.
I can say this, that this year, based on the calculations, no additional funding was put into that account.
Oh, well, then there are going to be some people in the public that are going to be very curious about that calculation, because you, as a state, had a surplus. So that's going to be kind of interesting to see, because that is one, well, I'll just say there will be, well, I at least will be very interested to review the calculations on that, given the statutory formula for how that happens. Because I know there have been times in the past where no money has been deposited into that account, but it has always been a year where the state globally or collectively ran a negative balance. So they came in with, they were over budget essentially. So, all right, that is curious, but good to know. Thank you there. All right, so I guess in terms of the Medicaid expansion fund, we can surmise that the revenues coming in that have been a summary of previous commitments to the, thanks, Nate, previous commitments to the Medicaid program that ended up being now matched at a 90-10 match instead of 70-30 or all state funds in the past, plus revenues associated with the ballot initiative. Could you go back to that slide?
Sure.
Thank you. So that was about $140 million of revenues. And then the expenditures, $100 million, recognizing a lot of that was for individuals who are not eligible for the program other than the maintenance of effort requirement. The enrollment is artificially high, but even with that artificially high enrollment, there's still net revenues over expenses, a substantial amount of money, and the program each year is building up a balance based on its fiscal sustainability. So I know there were a lot of questions over the years as Medicaid expansion was debated as to how it was going to be a burden to the state. And it looks like for everyone to have peace of mind that there's enough money to cover the expenses of the individuals, given the revenue sources, even with higher than expected expenditures for the public health emergency. So, okay, that is helpful. Thank you very much for your presentation. We appreciate your work in putting all of that together and accounting for all of this, what I will say, financially chaotic streams of funding from different enhanced federal funds, different new federal legislation, and then keeping that all straight for the program. So that's very helpful.
Thanks,
okay,
Michael.
And you'll make that presentation available?
Yeah, I've actually already shared
out?
it with Sharon, so
Okay,
she should send
and
it
then
out.
we'll post it on the MAC webpage for long-term documentation. All right, well, that is the end of our agenda that we had scheduled for today. Well, I guess I'll just say in closing, we do have a subcommittee that has been established for working on the bylaws. And if you're interested in participating in that, again, if you could send your information to Sharon. And then Stephanie's working on another subcommittee trying to find people to participate in the MAC. And if you're interested in that subcommittee, also if you could let Sharon know of that, and then we'll get those subcommittees up and running and try and get those working on their stated purposes. And with that, we will go ahead and conclude our meeting, and we'll be back in touch on November. And then if, just as a general statement, if any member of the MAC has a topic that they would like to see discussed in a future meeting, if you can pass that along to Sharon so we can discuss it in our executive committee meetings as we plan future Medicaid agenda plans, then we'll take that into consideration as well. All right. Thank you, everybody, for your participation today, and we will be adjourned.
Thank you.
Thank you.
Thanks, everybody.